And we're very fortunate to have folks from Cooper who are themselves visionary and courageous and wonderful and bright and caring folks that are really out in the forefront of pain management in all the ways that we need them to be. What you're going to find in this next presentation, and there will be Q&A, it's not just technology. There's a lot of heart, but as I said, there's a lot of courage and vision too. So we're going to hear about not just the future and the present, but the past, some of the mistakes that we've got to address, but some of the opportunities for us as we do. So with that, we have the brilliant Chief Innovation Officer, Dr. Michael Kirchhoff, leading a fantastic panel, Dr. Michael Sabia, and PhD Dr. Neal Lemon, Director of the Innovation Center at Cooper. Gentlemen.
Thank you, Mark. And thank you, everyone, for coming today. I'm Mike Kirchhoff. We'll do introductions in a minute, but what I wanted to draw attention to were the stories of Jelani and Riley and the stories that every patient brings to our therapeutic interactions. If you're a provider or support providers or create technology that supports providers, what's really at the end of that sharp end of everything we do for our patients and our communities are those patients. And every patient has a story.
With dealing with the opioid crisis, I started at Cooper at the beginning of February this year, so it's been 10 months. Preceding that at UPenn, I was also involved in some technology specific to the opioid crisis. One of the technologies was the development of a more sensitive fentanyl test strip so that it could be used to detect these so small amount of fentanyl is actually required to provide like an addictive dose. And there was a shortage there, and we were approached by a lot of public health agencies looking for low-cost sensitive fentanyl test strips to play a role in harm reduction. So I think there's a technology aspect there. Since joining Cooper, I've also been working with a lot of really good clinician informaticists like Dr. Kirchhoff, and also a broad network of providers. What first comes to mind is a project that we're currently working on with Microsoft and Doctors Couch and Cole and our Chief Information Officer, Dustin Hufford, and Dr. Kirchhoff, at creating better ways to monitor patients across health systems and even within our own outpatient service offerings within New Jersey and Pennsylvania, so that we can come down to the root of maybe prescribing, also having alternative therapy approaches being viewed by multiple providers, which might be dealing with some of these patients and not interacting with each other. Another initiative we're making at Cooper is looking at transition of care issues. There was a great session earlier today by John Wetzel looking at the vulnerability of people that are in the correction services being released with addiction problems, being released with behavioral needs that need to be addressed. Cooper is in a place to address those needs, and a lot of them are just being kind of released into the ocean without those services being readily applied. So we're looking at ways to engage within the judicial system directly so that before they start going to kind of self-medication and other routes to deal with maybe underlying chronic pain issues, that they come to us. And I think later on in this talk, we'll touch maybe more on the many multimodal aspects of treating pain, which can work as alternatives to simply prescribing oxy or having oxy on your bedside table, like Jelani was mentioning. It was a really great introduction because he also had the opportunity to self-medicate with marijuana, but there wasn't a lot of instruction or knowledge about how that could deal with his underlying pain issues, and that's something that Dr. Sabia and a number of our other providers at Cooper are really interested in getting to, like a medical foundation and providing good medical insight on how to use plant-based medicines to treat underlying chronic pain.
So as we moved out of the opiate crisis, we really needed to fix the error of our ways. So our initial fix was reduce prescribing, do education, help providers in the community understand what we're trying to do for them. And obviously, maybe not obviously to you. If you don't care for patients, you might not realize this, but if you've been on an opiate for 10 years and now you suddenly say we're not going to be prescribing for you, that's really not fair, right? So we needed to have alternatives. It wasn't enough to just say we're going to stop prescribing this. We needed real alternatives. And that first step was in harm reduction. So state of New Jersey said, hey, stop prescribing these substances, reduce your prescriptions. But how are we going to then further reduce harm? For those of you who do anything in the addiction space, for anybody who does anything in the PTSD space, for anybody who does anything in trauma-informed care, what we know now is that the neurophysiology of these patients in these communities is different than those that don't experience that. So it's not okay to just say, don't use opiates, right? Just say no, right? We know that doesn't work. And now we have the functional MRI data to show that those neural pathways have been changed by chronic opiate use, by chronic anxiety, by chronic pain. So we need to come up with new technologies, new pharmacologies to help fix those underlying neurophysiological problems. And one of the first things that came was buprenorphine, so Suboxone. And one of my roles in early bringing that on was the information technology and EHR implementation around, as is the case with many things that have a stigma attached to them. For those that were alive during HIV era in the 80s, there were all these hurdles to go through for HIV testing, right? Because for some reason it was different than every other test that I do. And then came along buprenorphine, and we had to do all these other things because, well, it's for addicts, and we're gonna make it a separate class, and we're gonna perpetuate the stigma associated with this treatment by making providers jump through all these hoops. So we had to meet those needs, and what we did is we still have to track every X-waved physician. Those are the ones that are allowed to prescribe these. We have to track their prescribing habits. We have to be able to report it to the state, and then also get all that information into the EHR, so order sets and pathways that would support the nurses and those caring for those patients, both in the hospital and the ambulatory offices. How can we reduce that harm? And then getting real numbers of what we were seeing in the hospital so that we could then make the business case for harm reduction programs, et cetera. And Mike's gonna tell us some of the things we did clinically at Cooper in that early harm reduction and medication-assisted therapies.
Sure. So speaking about the process first, prior to April 2021, physicians had to complete an 8-hour instructional course and nurse practitioners a 24-hour instructional course in order to obtain an X waiver, which gave them the ability to prescribe buprenorphine, partial mu agonist, and kappa antagonist as an outpatient for opioid use disorder or opioid dependence. So we were losing a lot of providers saying, I don't have that time, I'm not that interested. So we greatly improved and streamlined the process, specifically within our institution, and others mirrored our results, where the emergency medicine department with Dr. Kirchhoff, myself in pain medicine, addiction medicine with Dr. Baston, and EMS created a process where you can get X-waivered, have the ability to prescribe buprenorphine, in order to get your X waiver to help patients have one option to get off their opioid therapy. That, coupled with medication-assisted treatment, MAT, which has 3 medications listed in them. One is buprenorphine, brand name Subutex, Sublocade, Suboxone, Casipa, has several different names. That's an agonist-antagonist. Another one is methadone, brand name Dolafine, which is a pure opioid agonist. And finally, naltrexone, brand name Vivitrol, which is a pure opioid antagonist. That's an intramuscular injectable substrate that has a long half-life. So with these medication-assisted treatments, the ability to have the X waiver, that gave an option for patients to come off medications instead of just saying, go cold turkey. There's evolving data demonstrating that the relapse rate of patients returning to opioids is greatly diminished when there is medication-assisted treatment, coupled with the resources that rehab has to offer, the rehabilitation centers. So that's basically saying patients are living and not dying.
And I just want to call one thing out there because Mike had mentioned methadone. And I just want to, if anybody suffered from depression or anxiety, imagine this. Every morning when you wake up with your crushing depression, you have to get out of bed, go 5 miles from your home, stand in line, and get your depression medication. That's what we do every day for our patients getting methadone. So the one thing I'll ask anybody here who has the ear of anybody making any rules or regulations, that is ridiculous, because we don't do that for any other disease process. We don't go through special training for medications with respect to Suboxone, and we don't stigmatize patients by making them wait in line in the worst neighborhoods to get their medications for their physiologic dependence, for their rewired brain. So just going to put that plug out there, and that's an opportunity for Neal to talk about some of the things we're doing from a business perspective, business planning, and opportunity, because where we have friction, where we have failure, that's an opportunity for us to create good in the world, make the good easy, the bad hard, and create value not only for us as a health system, but for our patients and communities.
Thanks very much. Yeah, I would, since we're in the harm reduction phase of this talk, speaking a little bit about like the wild, wild west type scenario we are in pain management and looking at alternative therapies, and where we can step in and identify that sort of chaos or need for structure and put the weight of our providers behind looking at prescriptive solutions and ways in which we can work on a multifactorial basis across providers in different specialties to fully address issues of our patients. Some of that alternative therapy space, I know there's even people in the audience, myself and my family members included, that have suffered from chronic pain at different stages in their life. They don't want to take the opioids, but they're not exactly sure what the alternatives are, and they're looking for expert opinion, expert guidance on dosage, formulation, different things. Some of those alternative substances include CBD, marijuana more broadly. There's a lot of self-medication, people drink. What is the optimal solution for each person? I believe with, especially say the CBD space, there's a lot of studies. I looked at a review earlier this week, kind of a meta study, drawing on 2,300 papers involving CBD and pain. Broadly speaking, looking at lots of different indications and formulations and methods of administration. Broadly speaking, the researchers in California said, yeah, this is a promising alternative therapy or therapeutic modality to treat chronic pain, but there's still questions on the business processes by which to bring, that as a plant-based medicine into the point and to fund the kind of clinical evidence that's required to really be able to prescribe and have a health expert fully engage with that as a therapy. So one of the things that we're doing at Cooper is reaching out to the community in order to get support from the industry as well as patient groups like Jelani represents at Athletes for Care in order to synthesize a framework in which we can get that evidence and provide that through our providers to people asking those questions about alternatives to opioids. A great example of this is the work with Advanced Alchemy Labs and the discussions we're having with them and regulatory specialists as to how we would construct a clinical trial on a specific indication identified by Dr. Sabia to provide that proof of evidence through an investigator-initiated trial, maybe some industry sponsorship, and there's different classes of some of these drugs. So the CBD side, a little bit more straightforward in order to do that, combining with a holistic view of behavioral treatment. Some others, like Mike had mentioned, psilocybin, Schedule I class drug, a little more complicated to get the licenses required, but also looking not just pain, but pain is at the root of a lot of other issues, also contributing to PTSD, addiction, which we've talked at quite a bit so far, a lot of other human health issues. So I'll kind of save some of the things there for the future sessions, but there's also a lot of interesting future alternative ways to be looking at pain. And I know on the precision side, on harm reduction, Dr. Sabia is also involved in precision application through pumps. There's other types of ways in which opioids can be made safer. They are amazing drugs, but unfortunately cause a lot of externality issues as well.
And that brings us to some other current alternatives. Neal had mentioned pumps. I'm also going to mention ketamine. So that's we're learning that medications are being repurposed for neuromodulation, et cetera, ECT, essentially shocking the brain, new programs, et cetera, to sort of make that easier, less impactful, less side effects for the patient, but helping the brain rewire, increasing that brain plasticity. So from an information technology perspective, these alternative, we heard men talking about, how do you get the providers behind an idea, an evidence-based idea? Neal talked about we need to get this evidence, right? So once you get this evidence, how do you then prod the provider? So from a EHR and a medical informatics perspective, I look to change management, and one of the things I like to quote to many, many people that I talk to, especially when I have my safety hat on, talking about change management and changing culture in an organization, is that, one, you have to make it very clear what you expect of your people. Make it crystal clear what behaviors you want, give them the tools to do that behavior, and that's where most people stop, right? I told you to do this thing, and I gave you the thing, why aren't you doing it, right? Well, that's where culture comes in, and that's where the EHR comes in. That's where peer support comes in, having a good team. That last piece, after you tell somebody what you need them to do and give them the resources to do it, you then need to give them reminders in the environment to trigger that behavior so that they start doing the behaviors you need. And pain management and current alternatives is no different. So what we did for the EHR is, Mike did a great job educating folks on adjuvant therapies, blankets and meditation, et cetera. But then how do you remind a provider or a nurse at the bedside or an extender in the office to prescribe these, give education about these about these alternatives, et cetera? So what we did in the EHR is that we made them like medications, right? It's a continuum. I think many of you, we hear when we talked about buprenorphine, what I hear from folks in the community is you're just substituting one drug for another. And you're right? There are other ways to do that. And pharmacology isn't the end-all, be-all. So how do we get these other alternatives at the bedside, at the sharp end of the organization, to our patients? And one of those is to not only tell them what's expected of them, that work Mike's done when we talked about harm reduction in the opiate crisis, but also then give reminders. So build it into order sets, build it into policies and procedures so that you're ordering that. And guess what? If you order something, then I can monitor your behavior and I can give you feedback. Are you doing what you need to do? And then I know which patients got what interventions, and then we can do the studies and say, hey, look, meditation does work because I know which patients got education in meditation. I know what their pain scores were, and then we bring some other piece of technology to bear. I'm going a little bit into the future, but we're doing a lot of work around VR and AR, to really help, reduce anxiety, reduce pain, et cetera. So all these technologies, as we're prescribing them and using them in the clinical setting, the information technology that many of you create helps us track not only what patients got what interventions, but their outcomes. And then that builds the evidence that then moves the needle away from these destructive behaviors like overprescribing opiates and towards more holistic approaches to patients. And this has had a major impact on your clinical practice, I would imagine.
Absolutely. So clinically, I think dividing the alternatives into the implantables would be something worthwhile to touch upon. And that has two main categories: intrathecal drug delivery systems and intrathecal pump, or spinal cord stimulation dorsal column stimulators. These devices are not new. They've been around for decades, but the technology has advanced. Looking specifically at patients who suffer from cancer pain, there is still a growing body of research demonstrating the efficacy of opioid analgesics to treat both acute and chronic cancer pain. Just that cancer population, I stress that. The biggest drawback is the side effects that they suffer, mainly being constipation and sedation. So what good is it if your family member or friend is spending their last few months asleep on the couch all day because their pain is being controlled, but they're feeling untoward side effects from the opioids? So the main point of the intrathecal pump is it holds a reservoir of an opioid or other FDA-approved medications that's connected to a small catheter that's placed in the cerebral spinal fluid in the spinal canal that delivers 1/300th of the oral dose. So if a patient's on 300 milligrams of morphine, they'll only need 1 milligram a day with that intrathecal drug delivery system, offsetting the side effect profile, giving analgesic relief. With the spinal cord stimulation, it's a similar process where something's implanted, but it's a drug-free system. It's an electrode that's placed in the epidural space. And with an anode and cathode and a positive and negative field charge array, it interrupts the pain signals traveling from the spine to the brain. So without any chemicals or drugs, it's an electrical way to reroute those pain signals. So this is not a one-man show to manage these types of patients. You really do need a multidisciplinary team of neurosurgeons, anesthesiologists, addiction medicine specialists, physiatrists, physical therapists to work collaboratively to help manage all the intricacies that go along with dealing with these types of patients. And we're fortunate that Cooper has all of these subspecialists under one umbrella to provide the best outcome and getting patients functioning again.
Yeah, and many people in this room and many people out on that floor are currently have created already and are marketing alternatives. And one of the things we've charged Neal with doing is meeting these companies and bringing these technologies in. Tell us a little bit about some of the partnerships that we've done. I know you mentioned a few of them.
No, absolutely. That's kind of the other side of the coin of the Innovation Center, in addition to supporting innovations originating out of Cooper and our providers and our partners at different universities across primarily New Jersey, Pennsylvania, is to also work with private enterprise to bring the cutting edge into Cooper and to work with them in clinical kind of validation of their technologies. And there's different ways to do that. You know, if it's a company like Pfizer with plenty of money that's coming in and has a new technology, or say we're looking at wound management and treatment of pain, and there's a lot of activity in that space given our trauma center, you know, they can pay full freight, they can do a clinical trial with us, they can dictate terms, they might have a large team, but we want to engage them and bring them into Cooper to do those trials. Also, it's important to note Cooper does have a very diverse patient population, which some of the other health systems do not have. So we have received a lot of interest from a lot of established companies and even some newcos that want to round out their patient experience using their technology by engaging with Cooper. So I think one of the main things that we can do is be open to those opportunities, but also I'm working with a number of companies that are starting up, raising money, looking for grant funding, non-dilutive funding to support kind of that clinical proof of concept. And one of the reasons I'm at Cooper and not at my previous employer is I really felt a sincerity amongst the providers and a willingness to do right by the patients and embrace change and try to bring new treatment methodologies in and contribute to those and their clinical expertise when they were able to. So we're in the midst of doing that. There's a couple additional providers here that are in the space that aren't on stage. We have a Neuromodulatory Institute, a residency associated that, looking specifically at multimodal approaches to neurological disease. And in addition to Dr. Sabia, who represents the pain component of that, Dr. Basant Pradhan, who also was a monk, lived with the Dalai Lama for a number of years, and became an expert in kind of behavioral aspects of dealing with pain and classical medications as well as an MD. But we're also looking at how to incorporate mindfulness, behavioral modification, in addition to alternatives in the pharmacy space, transmagnetic stimulation, all the different opportunities to really make an impact directly for the patient, and also steering away from some of the externality issues with using an opioid systemically to treat pain. And I think as an adjuvant, a number of these alternative therapies may work, and you might have a focal application of an opioid, like in a pump, or, for example, a hydrogel. There's a new product that had initial clinical studies this summer called Hydrofill, where they were injecting a hydrogel with an analgesic into the cracks of the spine during damage or during surgery to get a slow release, non-invasive, but that could then be paired with maybe a CBD, a number of the other treatments that we're looking at bringing our providers together.
Yeah, and all those relationships and all those therapies you talk about really brings us to the future. And for me as an informaticist and as a patient safety officer, and really want to leverage the EMR and alternative ways of collecting data. What I'm seeing out in the ecosystem now, some apps developed by folks here now, is how can we track symptoms across the continuum of care, not only in the hospital. We talked about how we leverage the EHR to look at alternative therapies and those outcomes and get that data. But how do we do that out in the community? Because let me tell you, if you have chronic pain, if you have PTSD, if you have addiction, you don't want to be in the hospital. You probably don't even want to be in an ambulatory setting. So how do we push now, as part of the future from an information gathering perspective, how do we push that data gathering out into the community? And we're seeing a lot of app development around symptom tracking, et cetera, because we don't know how these things even interact. So, and we see this time and time again. Each of these therapies aren't specially unique snowflakes. Cooper is not a specially unique snowflake, right? It's the same story over and over and over again. People find things that work, nobody knows why they work. We may shun them because we don't have the data. Then we get the data, we're like, oh, look, they were right? So hydrogel is an example. Non-drug-eluting hydrogels seem to also work reducing pain and improving outcomes in orthopedic patients. Mm-hmm. And we're not really quite sure what those mechanisms are. Same thing with self-administered therapies. There are many, many companies out there tracking symptoms of depression, anxiety, and chronic pain, about the diet, their activities, self-administered substances like alcohol or cannabinoids, right? So that we can get that data out on the community and then get that to really look at what's really changing, what's moving the needle with respect to pain control, et cetera, et cetera. If we don't have that data, then it ought to providers, to docs, to we are scientists, then it seems like voodoo. Well, it works for me. Well, why does it work for you? I don't know why. So we should not be dismissing it. What we should be doing is running towards technologies to get us the data to then make informed decisions about what works for patients. And what Mike and Neal said is, it's multimodal. So what works for one patient might not work for another. So how do we use technology and data to then create expert systems that help identify patients who with, you take A, C, and E and put it together, it works for them, whereas B and D works for the other patient, right? So how do we get that data? How do we get those expert systems? And the only way we're going to get that is measuring it, and measuring it out in the community every day, every hour from the patient. So wearables, apps, self-reporting, all very, very, very important for us to do the next trials and to make the next arguments for the latest futuristic adjustment in pain management. And Mike, what do you see coming down the pike for your clinical practice?
Sure. So a big part of the future lies in patients with a history of physical or emotional trauma and how that can manifest as PTSD later in life. We know those emotional traumas are deep-seated and ingrained in part of our limbic system and thalamus, and that disrupts the glutamate pathway. So those patients have these behaviors that they ruminate upon, and through the Timber protocol created by Dr. Pradhan, one of our psychiatrists, these patients receive a low-dose IV ketamine infusion, and they start to become disinhibited, and that helps modulate their glutamate pathway that was initially disrupted. And through a delicate trained personnel like a psychiatrist or behavioral therapist, they revisit and relive part of that trauma with the patient in the disinhibited state. Then they bring in cognitive behavioral therapy into that and help try and detach them from that situation. So instead of just normal talk therapy, behavioral therapy, you're using a compound of ketamine that works on a specific neurotransmitter of glutamate with a lot of research. Being an anesthesiologist, ketamine's been around for a century. We put patients to sleep with it in the operating room all the time. But at microdosing with behavioral therapy and in the right context can put patients in a different state of mind and allow them to gently bring back that memory and really detach and become accepted from it instead of having to relive it at random times of the subconscious. So we're fortunate that we have the first fellowship program at Cooper to train providers in order to how to undergo this type of therapy, which is the neuromodulation mindfulness fellowship at Cooper.
And Neal, how do you see creating value for our communities and our organization from all these cutting-edge technologies?
Building on what Dr. Sabia said, so my background before I got on the business side, I did a PhD in neurophysiology and research in that space, and part of that research was looking at how memories are formed, episodic memories are formed, traumatic memories are formed, and going all the way back then, because I'm significantly older now than I was in my late 20s, it was already known that there were ways to create these disassociations between pain states and then offer therapies. I was doing preclinical work using propranolol, a beta-adrenergic receptor antagonist, which was shown to blunt the effects of, strong episodic memories, and then it was rolled out in a clinical trial done at Harvard with veterans that had PTSD. Currently, there's a lot more acceptance for psilocybin, a Schedule I class drug. There was a 1-hour special on NBC last week in which there was a 15-minute segment in which they went through the way a lot of veterans that have PTSD are working with specific groups, including Riley Cote, in helping addressing their PTSD through use of psilocybin and cognitive behavioral therapy and working through that. We want to also embrace that. Part of that is Dr. Basan Pradhan, who wrote the book on timber, cognitive behavioral therapy, which can be combined with alternative approaches to create and rewire the brain to address not just chronic pain, but other neurological disorders. I think that's definitely one of the future aspects, is looking into these multimodal treatments, like the MEND team was speaking about, including nutrition in that, within that bucket. I think there's also some kind of Star Trek, Star Wars type future opportunities on the technology front to treat pain. When I was at Penn, I did a lot of work with the neurosurgeons and neurologists looking at brain-machine interfaces. Dr. Sabia touched on that as well. There was a recent study in which monitoring using really sophisticated sensors, monitoring the anterior cingulate cortex, provided information on the pain signal. The feedback was then given for stimulation of the prefrontal cortex, and on an ongoing basis, it was able to mitigate or reduce the level of pain. We need to be open at Cooper, and we have a great team of neurologists as well that are open in our neurological institute to making connections on that cutting edge and seeing if they might be solutions for specific groups of people suffering chronic pain.
So as you can see, there's a lot coming down the pike, and it really certainly is multimodal. We just need to make the good easy and the bad hard. So I think we ran over a little bit. I don't know where we are timing-wise, but we certainly can take questions on the side if you need the stage back, sir.
Absolutely. So Q&A. Any questions for this brilliant team? I heard some party music in the background, too. Yes?
Yep.
Oh, way in the back. Of course, way in the back. Want to meet me halfway?
You're getting your steps in.
There it is. Count those. Okay, thank you. Here you go.
Thank you. Thank you for your talk. My name's Meryl, and I'm from Orlando, where I'm Chief CRNA at our Level 1 Trauma Center. And I was curious about what we see are patients who have some type of treatment program that they're in, and then they either have a traumatic event or something that brings them to the operating room. And how does the communication work to the anesthesia team in the OR? Do you drive that? Is there collaboration? What I find is that we have a wealth of knowledge in our group. Wonderful anesthesiologists, primarily, who are resistant to ketamine. They're resistant to other ways of doing things, and I think that we kind of dropped the ball a little. These people suffer more than they need to because we're kind of like putting a gap in the trajectory of their treatment.
Yeah, we do see that a lot, and we do many things to help sort of smooth that handoff transition communication. One of the things is tracking these other devices. So we went a long way to tracking patches and documenting patches and pumps, et cetera, in the EHR so the team is aware of it. Part of it is also educating all the providers, not, providers, if you're on Sublocade, can you get opiates? Can you, and one of the other things is also, the pendulum swung a little bit the other way, right? When there's acute pain, you have acute pain, and you need to get on top of that. So part of it is a lot of work Mike's done, educating top to bottom in the organization what we need to do for these patients, depending on what therapies are on, et cetera. And then the other thing we've done is invested in people. And with our addiction service, not only do we have a very active addiction service, but now we have 24/7 inpatient addiction coverage with specialists that are trained in these medications and other therapies, so that if any other clinician has a question about how to address this, should I give them opiates, should I not, is it safe to do X, Y, or Z with them, there's an expert in-house 24/7 that can answer those questions, and then we also push that information electronically in the chart to make sure it's tracked across the continuum of care. But yeah, we struggled with that for a very, very, very long time, and we're only just starting to get a handle on that by putting positive workflows in the EHR to track it, and then the education, and then also provide that consultation service to answer those questions. We use Epic.
Doesn't everyone know?
No,
Or is
not
it-
everybody.
No, just kidding. Any other questions? Well, I know, we talked about a couple different health population groups, and we've actually had great representation among both the program and the people here with former elite athletes. But you had mentioned the 85% payer mix of population that you serve. Cooper's been around 130 years. In looking at that, we talk here, and we were over at the impact stage earlier, promoting some programming around health equity, and also the challenges that we all face with social determinants of health. Can you tell us some of the things in health equity and social determinants of
Sure.
health?
I mean, that's something that's super big to us. I mean, it's big in the news now, and there's a big federal push on it. One of the things we want to do is create the next greatest thing on that. So to that end, not only do we have a social determinants of health team, but we want to bring in people outside. So Cooper, along with Enable Health, will be sponsoring a social determinants of health hackathon with data sets to really look at, can we track, can we use AI and machine learning, can we use these different data sets that clinicians normally don't use, social work, healthcare, maybe even justice-involved care. We've done some studies in the past with other data sets looking at that overlap. So there's information and knowledge to be gathered from looking at these data sets. So the next big thing for us is to look at that data more systematically. And one of the other things we're trying to do, to the point, right, there's data scientists, and I'm sure they can come up with some great data visualization about people access to food, stable housing, access to care, what those communities are, what your zip code is, and how at risk you are. But in the end, they're not the ones using the information. So to have a more holistic, systematic approach to social determinants of health, the hackathon's also going to have not only data scientists and coders together, but each of those teams will then have a social scientist as well, so that we have the social worker, the lawyer, the MBA, I guess they're social scientists too, right? Because you got to make money to make a product to get out there. But the idea is getting non-computer scientists on those teams to look at, to discuss. I'm the end user. If I'm an MPH and I'm looking at harm reduction, I need to be the voice telling the coder how to use these data sets, because what information do I need to make the decisions at the sharp end of the organization to bend the curve around the care of these patients and communities. So it's not enough to just have the data, it's not enough just to have technology, but you have to have the end users really understanding how you're going to use that data so that you create meaningful applications and interpretations of that data to then really meet the patients where they're at with the resources that are available to them.
Yeah. I think to add on the answer to that question, I've been really pleased with the hackathon, the level of engagement, the tight engagement that our community health partners have had with Cooper, and that's an engagement that goes back decades, but bringing in the community needs assessment, really getting real granularity as to some of the SDOH issues, which we're then putting out to the community and looking not only for solutions, but also problems from them. So to really make it kind of a grassroots effort. And even though we've been just soliciting engagement for this hackathon over the last couple months, there's been really good engagement from industry as well, from the health IT community, but also from some of your larger health companies that identify this as an issue and will bring their brains to hopefully the hackathon to help come up with some of the solutions.
That's excellent. And just to let folks know, Cooper will be featured at VIVE, the coming conference that Health will be holding on in Nashville at the end of March. So we'll look forward to seeing this impressive team from Cooper again. Thank you, Cooper.
Oh, there's another question. We can,
Oh,
if we're out of time, I don't know if there was time for a
wait,
question,
hey.
or we can.
There's always time for another question.
Absolutely.
Hi, so I guess I just wanted to know, I know you guys were briefly talking about CBT and that compound of ketamine as far as a treatment for pain management. And I went to a talk, I think it was like yesterday or the day before, they're all like blending in as far as using psychedelics for improving mental health. So I'm curious as to like what the informed consent process looks like for your patients, as well as like the monitoring for patients when they're in that altered state, and if you guys, like with psychedelics being something that's being talked about more now, is that also a form of treatment that you guys are using for your patients?
Yeah, we're not currently using the psychedelics, but ketamine is a big part of our practice. And you're absolutely right. Patients need to know risk, benefits, and alternatives, and they need to know, and those alternatives are important. So this is why we feel we're particularly well suited to talk about these with our patients, because we offer the full spectrum of treatment, from medications to ECT to talk therapies to these other more advanced therapies. So that all those are available to patients, and then understanding what works best for the patient. And that, to your point, it's hard to have that informed consent conversation because we know these therapies work for certain patients, but now the next step is to identify which therapies work best for which patients and have that personalized medicine, whether it's part of understanding their genome or part of their behavior or what their trauma was, knowing something about their physiology so that we can pick the best solutions for them. The other thing, to your point, is the monitoring in the environment. What we find when we put patients in these states, the environment becomes very, very important. And I did want to comment, this is a nice room. We got flower, we got the leaves, it's very calming. Green's a nice color for calming. That's not lost on me, and it's not lost on my colleagues. You can't do these therapies in a room with a tile floor and a hard bed and expect that you're going to have the outcomes you want, right? Because you're restoring plasticity to the brain, you're reliving these traumas. That environment has to be conducive to that, and that's one of the things we're looking at from a business development perspective. Is the next step creating spaces for these patients to get these advanced therapies that is as healing, the space is as healing as the therapies we're bringing to them. And that's very, very important and an insightful question. That it's something we're definitely looking at.
Yeah. It's really interesting, because there's a business consideration there. I think on the technical side, and Mike touched on it, Dr. Kirchhoff touched on it, is also the use of companion diagnostics, like traditional ones that you'd find, markers in the blood, which I have some disclosures regarding companion diagnostics and neurological treatments for neurological disorders to see if those can be part of the solution, but also brain imaging opportunities, not all the way necessarily all to MRI, but some like near-infrared brain imaging, different alternatives to help with some of the patient stratification and tracking of efficacy of treatment beyond just asking if you feel better. So. Yeah, there's multiple components to that, but also when we're working with drug companies, if you look at successful clinical trials, you see there's a massive increase in the success for approval of drugs if they have the appropriate companion diagnostics, and we're also looking to try to tie that into these alternative multimodal approaches to treating these neurological disorders.
Yeah, that's a good point.
Excellent. Well, again, thank you so much for just a fantastic panel. We wish you well at the next conference. We also hope to see everyone out that Health is going to be hosting, Vive, at the end of March. Clearly, you guys are top of your game. Thank you for sharing just the exciting innovations that are going on at Cooper. I know you'll be available for networking if anyone isn't rushing out for a flight. So Mike, and Neal, we wish you well. We'll look forward to staying in touch. This narrative will continue. Any final questions before we let the team from Cooper go? Excellent. Thank you so much.
Thank you.